Welcome to this video on the clinical continuum of infertility, assisted reproductive technology or ART, and ovarian hyperstimulation syndrome or OHSS. We will systematically map the pathways of etiology, intervention, and iatrogenic complication. Primary infertility is the inability to conceive after 1 year of unprotected intercourse. The diagnostic threshold is accelerated to 6 months for women 35 years or older. Infertility factors are broadly split between female, male, and combined or mixed causes, with a significant percentage remaining unexplained. Male factor infertility, such as azoospermia, is classified based on hormonal profiles, which can be pretesticular, testicular, or post-testicular. This matrix helps in differentiating the underlying pathology and subsequent clinical examples. Female infertility drivers are commonly classified anatomically: the ovary, the fallopian tube, and the uterus. Ovarian dysfunction, often anovulation, is the most common and treatable cause. Fallopian tube issues are often mechanical, like those resulting from pelvic inflammatory disease, while uterine issues are structural. A 28-day clinical assessment timeline guides the diagnostic workup. Key steps include baseline hormonal checks, monitoring of follicle growth via ultrasound, a reserve check, and confirming ovulation via a luteal phase progesterone level. The assisted reproduction pipeline begins with controlled ovarian hyperstimulation, or COH, to recruit 6 to 15 eggs. This is followed by aspiration and retrieval, fertilization, and finally embryo transfer for optimal implantation rates. Note that retrieving more than 17 eggs indicates dangerous overstimulation. The intervention paradox illustrates how COH sets the stage for ovarian hyperstimulation syndrome, or OHSS. High-dose FSH maximizes IVF success, but leads to a hyperestrogenic environment. The HCG trigger is the final insult, initiating a massive pathological vascular response if the egg count is over 20 or estradiol is above 3.5 OOPG per milliliter. The pathophysiology of OHSS is driven by a massive spike in vascular endothelial growth factor, or VEGF, triggered by high estrogen and HCG. VEGF causes profound vascular permeability, leading to intravascular depletion and extravascular accumulation. This results in hypovolemia, hemoconcentration, and fluid shifts into body cavities. OHSS is temporally classified as early or late onset. Early OHSS, occurring 3 to 7 days post-HCG, is driven by the exogenous trigger and is generally self-limiting. Late OHSS, occurring 12 to 17 days post-HCG, is driven by endogenous HCG from a newly implanted pregnancy and tends to be more severe and prolonged. The Mathur classification defines the severity of OHSS. Symptoms range from mild abdominal bloating to severe ascites, and critical conditions involving tense ascites, large ovarian size, and systemic thromboembolism, often indicated by specific renal and laboratory markers. Clinical management for severe OHSS involves 3 main pillars: fluid resuscitation and tracking, thromboprophylaxis, and symptomatic relief. A critical adjunct is the use of colloids, such as 20% IV albumin, to increase oncotic pressure and pull fluid back into the vascular space.